All right. Well, hello, everybody. Glad that you can join us for this latest webinar. This is Creative Healing for Youth in Pain's webinar on gut feelings, trying to understand pain in pediatric IBD or inflammatory bowel disease. And our speaker today is going to be Dr. Shervin Rabazadeh. My name is Rebecca Cherry. I'm a pediatric gastroenterologist in the Philadelphia area who sees many patients with chronic pain, particularly related to the GI tract and other gastrointestinal symptoms as well. CHIP is an online nonprofit organization that empowers youth living with chronic pain to heal by altering the brain's pain circuits through exposure to creative healing experiences, educational resources, and peer support. First, let me introduce Dr. Rabazadeh, or I'll let him introduce himself.
Thanks so much, Rebecca. Such a pleasure to be here, and really appreciate your invitation as well as for Chip's invitation and their hard work. So I'm Shervin Rabizadeh. Like you, I'm a peds gastroenterologist. I'm in the Los Angeles area at Cedars-Sinai. I am the director of the Peds GI program and inflammatory bowel disease here within the FWGIA Inflammatory Bowel Disease Institute at Cedars, as well as the chair of pediatrics within Cedars-Sinai Guerin Children's. And so my career has based on inflammatory bowel disease, and happy to be here to talk to you all.
So now, drum roll, we are ready to begin. Okay, thank you so much for joining us.
Thanks so much, Rebecca. Really appreciate it.
So, I'm going to jump right in with there seems to be a lot of confusion. There's always been a lot of confusion between IBD and IBS. And I will ask you in a moment about the difference between them. But to start with, can you explain to us what is IBD?
Yeah, that's a great question, Rebecca. IBD stands for inflammatory bowel disease. And it's this group of disorders that are linked together where you have a dysregulated immune response or defense response that leads to chronic inflammation in the intestinal tract. It presents at a variety of different ages, usually has some genetic propensity. You have some genes in there that are susceptible to it, but set off by certain environmental factors, relationships with microbiome, probably, potentially psychosocial factors, so on and so forth. And then when the disease ignites, when it comes out, it's activated, it's lifelong, it's chronic. Most patients have some sort of intestinal inflammation, but there's also non-intestinal symptoms and manifestations such as problems with growth or joint or liver or kidney. So it spans just beyond the GI tract. And pharmaceutical companies have helped mainstream it a little bit with the number of medications that now have commercials on TV. You all know the jingles for Skyrizi or Tremfya or Rinvoq and all of those. So it's helped in terms of the publicity from that standpoint of what IBD is. But in the end, it comes back to this chronic, lifelong, at times debilitating disorder.
Yeah. Um, and and so going back to that earlier question of IBS, what's IBS and how is that different?
Yeah, I mean, you and I have been in this business for a while, so we know the troubles of having these initials that are so similar with similar shared symptoms, but being very different entities of disease and not mutually exclusive. You can have patients with both. But IBD, as we talked about, is inflammatory bowel disease. IBS is irritable bowel syndrome. Give the audience a little clue into medical terminology. Whenever we put an S or a syndrome on something, it means that there isn't one test or one ability to kind of figure out that somebody has it. It means usually there's a constellation of symptoms that come together and have it. Where the two kind of come together is that they predominantly involve intestinal symptoms. They can have diarrhea, they can have even constipation can be shared between them. Occasionally, you see blood in the stool from either of them. Abdominal pain certainly would be the case crossing over them. Where they differ is how the pathophysiology of these diseases. We talked a little bit about IBD being a dysregulated immune response, your own immune system attacking your intestines and causing an inflammatory response there. IBS is different. We don't understand completely all the mechanisms of IBS. There may be some interconnections with the immune system as well. There's some data and evidence to show that there could be some microbiome reactions with the immune, nothing to the extent of the IBD world, but there may be there. But there's also a lot of intertwining with the functional aspects of the GI tract, how things are moving through the system, or what we call motility. Um, I often tell patients that the GI tract is not a lead pipe. Things just don't move through it like your plumbing in the house. It's constantly moving, squeezing. It's incorporated of more nerves in your intestinal tract than there is in your spinal cord. And that's that coordinated approach of being able to one segment squeeze, the next open up, squeeze, open up, and move things along. Well, when things are not in sync, when they're a little bit off, then you get these motility issues and thus the symptoms that lead to IBS. The other areas that it differs is also in the treatment approaches and what you worry about long term with these conditions. IBS is more often a quality of life issue, and that can be severely debilitating. Somebody can be homebound because their symptoms are so severe, and at the flip side, it could be milder where somebody's fully functional but still not comfortable and having quality of life issues. And IBS is much more common. You're talking about 15 to 20% of the population. IBD, much less common, so you're talking about less than 1% of the population. And you get quality of life issues as well there, but you also have long-term risks when it's not treated, like cancer propensities are increased, or complications of your disease, like scarring of your intestines, or developing these extraintestinal connections that we call fistulas. So all of those are possibilities. And where they also diverge is in treatments. So IBD, the treatment is controlling that immune response, dampening what is activated and trying to put a control aspect to the immunological system so that it's not revved up, it's not causing that hyperinflammatory state. While IBS, it's more about trying to get that functionality back to the GI tract, whether it's working with the gut microbes or whether it's dealing with things that settle the nerves down a little bit and try to re-coordinate, or whether it's ability to kind of coping skills and how you deal with the symptoms and how you interrelate there, or mechanisms for yourself in terms of kind of calming the dampening. I know you do a lot of hypnosis and various things like that. So those type of techniques really differentiate it all.
And then just a question for you about diagnosis. To be diagnosed with inflammatory bowel disease, do you have to have a colonoscopy or an endoscopy?
Yeah, great question. We often talk about when we dose, there is no one test that diagnoses inflammatory bowel disease. It's pieces of a puzzle being put together to create that diagnosis. So it starts with where everything starts. What are your symptoms? What is your history? It involves checking some of your blood work, stool testing, make sure we don't have an infection, doing inflammatory testing in the stool like a calprotectin, and then blood inflammatory markers, blood counts, looking at anemia and so forth. But those are all the screening evaluations. And when it's suggestive, then you need to go to the next level evaluation, which is looking for endoscopic or some sort of radiologic evidence of the disease. Most often it's going to be endoscopic. And yes, most all patients with inflammatory bowel disease are going to get an endoscopic evaluation, an upper endoscopy, a colonoscopy, to look for the disease. And really the purpose of that is, one, to kind of define the extent of disease, to understand what it looks like; two, to get histology, to biopsies, to again understand where the disease is at, because that has implications on the treatment and how we do it long term. But there's some IBD patients whose disease is in areas not routinely accessible with the garden variety upper endoscopy colonoscopy. And in those patients, you could diagnose somebody based on imaging, like an MRI or a CAT scan, where you're looking at the mid-small bowel, or relatively newer technology like a capsule endoscopy, or call it PillCam, which travels through and takes a whole bunch of pictures. And sometimes even we have endoscopic techniques that get to that area deep, deep into the small bowel, done by our more experienced interventional gastroenterologists, something called a double balloon endoscopy or a single balloon endoscopy, if we really need to visualize that better with the scope and get biopsies from that area. So the simple answer to your question is yes, we do need endoscopic evaluation when we're diagnosing somebody with inflammatory bowel disease. To just go a step further and say, do we need that with IBS?
That's
And
exactly going to be what I
yeah,
asked. Yeah.
I knew that's where you're going. Do we need that with IBS? And, again, that syndrome is having a constellation of symptoms that fit this profile right there. So no, you don't need it with IBS. Do some of these patients end up getting it? Yes, because as I started off by saying, these two conditions have so many similar symptoms, sometimes it's hard to decipher. And sometimes your screening tools, like your blood work and stool test, can be even normal in IBD patients. So if the clinician is strongly or just hinting towards that suspicion and wants to rule it out, they still may end up doing an endoscopic evaluation. For the IBS, usually it's ruling out the inflammatory condition. For the IBD, it's ruling in because you're strongly suspicious in that type of situation. But IBS does not need an endoscopic evaluation if the symptoms really fit that classic criteria and you're reassured by everything else.
Great. So switching gears just a little bit to the youth and pain. That's really what we're here to talk about. What is distinctive about youth or adolescents? And I know that there are some younger children as well who have IBD, but let's focus on adolescents for the moment. How are they different from, let's say, adults with
Yeah.
IBD?
Just honing in on a group that sometimes gets a little bit um, dismissed, so to speak, in terms of identifying things that make them individualize in their approach with the inflammatory bowel disease. And that's those adolescents and the young adults right there, because they oftentimes get grouped into very similar to the adult disease. And then it's different for the younger children right there. But there's some, as you say, there's some unique aspects for the adolescent that you want to think about. One is that uh, anywhere between 10 to 40% of IBD patients will present with growth issues. So oftentimes they're not staying up with growth in terms of height stature as their peers. They've either fallen off their growth curves where they were maintaining a percentile fallen off, or they're well below what we would estimate them to be in terms of their mid-parental height. And some of that interrelates with being even delayed in the pubertal process right there. And so these can also not just be physical manifestations of their disease, but also have a psychological impact, given that they're smaller than their peers and they don't feel like they're keeping up. And we all know the troubles of middle school and what that world is. And just imagine if you're the smaller side and you're more frail and you're having health issues and you're missing time and so forth like that. So that is one unique aspect of the adolescent. Um, Touched on a second unique aspect, which is puberty and having that delayed puberty, which is not uncommon, happens in about, again, a quarter of the patients, more common in patients with Crohn's disease than ulcerative colitis. And we didn't talk about those when we're talking about definition of IBD. And we're trying to get away from that labeling and maintain the different phenotypes, but still that's common terminology that we'll use. Crohn's being disease anywhere from mouth to the anus where the inflammation can happen, and ulcerative colitis being that inflammation is related to the colon. They can have, with the pubertal issues, delayed menarche, so their start of their menstrual cycles is delayed, or having irregular menses, and then lack of breast development, testicular enlargement all go wrong with that delayed growth right there. And then the other thing to kind of harp on is the psychosocial issues. That is definitely impactful with the adolescent group. And you have psychosocial issues that's going to interfere with their physical activity, that limits their social interactions, their self-esteem, body image issues, especially if they needed steroids, and or if they're on the smaller side. It disrupts their education. And that's their job, is education. They're going to school, and now they're missing school for months upon months or weeks upon weeks or days here and there, and they're not into that social environment or that development of their brain and their capacity. Their impaired growth, we talked about, their delayed sexual maturation and puberty, all of that impacts how successful their treatment's going to be. So, we talk about IBD as having a low mortality, so low death rate, but it can have such lifelong challenges and psychosocial and functional issues that can impact so many other aspects of their life.
When you talk about those lifelong issues, what what really are what is your goal for an adolescent with IBD?
Yeah, I mean, people who know me know that I say the same thing over and over and over again. The learners always in the room are like, "Wow, you repeat the same thing over and over again." I'm like, "Yeah, I mean, we say the same things." And one of my isms is always, "I'm not doing my job if I'm not getting you back to doing all the normal things that you need to do as a child." So whether you're a young child or adolescent, we want you back in school. We want you on the team. We want you in the music program. We want you doing all the things that you love and want to be a part of and enjoy that life. The disease should not define the patient. The patient should be the one who is living their life and doing, everything they want to do, and that's our job to get them there. So that's our goal in terms of their well-being, in terms of getting to the aspects of their life. We have a lot of medical goals, obviously. How we're going to get there is that we're going to treat the patient medically. We're going to treat them from a psychosocial perspective. We're going to treat them from a dietary perspective. We're going to treat all aspects in a holistic approach. And that's been associated with better outcomes in the long run. Medically, our goal is to get to the point that we can look at the disease, whether it was endoscopic or radiologic, and see that everything is healed.
Mm-hmm.
That's where we want to be.
Right.
That's that remission state associated with the best outcomes overall. Still, you have to stay on your treatments when you get there because that's treatment maintained, induced, and maintained. But that's associated with the best outcomes there. And then from a dietary perspective, we want to make sure that you're nutritionally sound, that you're regaining any weight loss that you had, you're back on the right area of the curve, you don't overgain weight, that we take into factors that if you did have to have steroids and how to fix that. From a psychosocial perspective, everything we just talked about right now, getting that functionality back in life, getting you as functional as we can, getting you out there and letting them live their lives.
You know, when I've taken care of patients with new diagnoses of IBD, oftentimes, although the kids might not be thinking about it yet, the parents immediately are wondering about the long-term implications for are they going to be able to have children? Are they going, and I think teenagers are often wondering, am I going to be able to have typical romantic relationships? Um, so what do you tell them?
Exactly right. I mean, the parents, usually their questions are relating to, is this disease lifelong? Will they need medicine forever? Did I give them this? Is there something that I did that caused this? What can I feed him or her? What are the risks, like the cancer risk and so forth? And those are all really, really important questions. And by the way, for all you parents, you did not give them this. You didn't do anything wrong. This is things that happen. Um, and we can talk about the other stuff. But from the adolescent perspective, their kind of view of it is, can I go to school? Do I tell my friends? Like, what do I say? I'm different. This is the time of life where I don't want to be different. I want to conform, but yet I'm different. And, how am I going to deal with this? Do I look like everyone else? Will I grow? Can I date, as you mentioned, and have intimate relationships? And even to the point that we get asked, like, will I die from this? Like, what will happen from that standpoint? And a lot of our advice and kind of how we go through this is talking to them about that, like I said before, you got to be a child. You have to be that adolescent. So, yes, Can you go to school? Yes. Not only can you go to school, you should go to school. We want you back in school. We want you functioning to that point that you are able to participate. And if we're not getting there, if you're having issues where you're not there to go there, then we got to work harder and get you to a point where you're able to do this. We encourage them to tell their friends. And that's going to be different. That's going to be an individualized approach. Some people are more insulated, they don't want to share. Others are very open book about it. And we walk and navigate through who this person is, who this child is, and what's going to be their preference. And sometimes it's that they want to give a little nuggets of it, and sometimes the whole story, they're open book, and sometimes they want to be closed. But we, even those who are close, we say you need a couple of people that are close to you that you want to share your experience with. Um, will they grow? Yes. I mean, we show them curves of other patients that once you get on the treatment, look at you. You're going to be that everybody's going to be like, what happened to Johnny? What happened? All of a sudden, wow, you sprouted out right there. And we want them to do all the full functioning. We want them to date, and we talk them through that. We talk them through intimacy, all of those discussions about, being open, having those disclosures, and not feeling different in that way. And everybody has a burden in some respects. So it's doing all of those things.
Um, so it sounds like it can be pretty stressful. And I'm wondering how often that how often people have difficulty coping or with difficulty with anxiety or with their mood.
Let's start with the medical side and give the medical answer to this. So this has been studied. Um, so what is currently unknown, and we get this question all the time, is whether the disease has a connection with anxiety, depression from an inflammatory perspective. And what I mean by that is being depressed, anxious, having psychosocial stress, does that actually cause inflammation or worsen inflammation? What we do know is those factors definitely make symptoms worse. So, you're inflamed and the symptoms dramatically increase overall. But when you look at the statistics of, let's say, take depression and anxiety, when you look at the populations of inflammatory bowel disease, about a quarter of those patients will have diagnosed depression, and almost half, about 40-45%, will have anxiety. No, okay, but what does that compare to the general population? The
Mm-hmm.
general population is about 10 to 15%. That's the estimates of general population, maybe closer to 20%. So you're talking about almost a doubling of certain of these sort of conditions. And it seems, though on par with other chronic illnesses, it's a little bit higher than some of the other chronic illnesses that exists. There's many contributing factors that come into play right here. I mean, a lot of them we've already talked about: being different, socially isolated, um, taken out of your school situation for the adults, your work situation, um, so on and so forth. But there is probably some interconnection, though not yet proven, from the inflammation side to that, and a lot of people doing works there. You want to look at some predictors of um, patients with some psychosocial aspects like depression and anxiety. Are they having stressful life events? Is there family dysfunction there? Steroids, when they're used as a treatment, can increase the risk of these type of issues. And then the disease severity. The more severe the disease, the more likely it is that you're going to see certain aspects of psychosocial issues.
And how about chronic pain?
Yeah. So chronic pain is a difficult one, and it's one that frustrates the patient, and at times misunderstood by the provider. Um, Technically, you have no nerve receptors in your intestinal tract. So you see these big, deep ulcers, and there's no nerve receptors there. But you have tons, and that makes sense, right? We don't want to feel everything that we eat. It travels through us, and we don't want to do that.
It'd be very distracting.
Very distracting. But there is tons of nerve receptors outside the intestinal tract. And those are what feels the pain situation in the variety of conditions overall. I'm always amazed by inflammatory bowel disease of its relationship with pain. And what I mean by that is that you could get a patient who has significant ulcerations in the small intestine and not an ounce of symptoms.
Yeah, don't feel a thing.
Don't feel a thing. And the first presentation is in the emergency room with eventually right lower quadrant pain and a picture where they're like tightening down their intestines and feeling obstructed. And people are like, oh, this is an appendicitis. And they do imaging and they're like, whoa, no, this is Crohn's disease. And that thing's been sitting there for months, maybe even years without a thing. And then you have other patients with much more milder inflammatory load when we look, but are having significant amount of distress and pain, again, relative to where their disease location is. The patients with the inflammation at the end of the colon, in the rectum right there, and having that urgency to go and that significant discomfort and that constant spasm that you have to go, something we call tenesmus. It's a very uncomfortable feeling to deal with overall. Um, Typically, the pain relates to the inflammation isk, we get that. But you also have patients who, one, have their inflammation completely treated, but still suffering from pain.
Mhm.
And we don't know how to explain that. Is it that there is some sort of inflammatory process, or is this kind of a hypersensitivity that's developed from the time of inflammation and their nerves are just overreacting and stuff? Those are all possibilities. And what I said from the beginning, that IBD and IBS are not mutually exclusive. So if IBS happens in 20% of the population, it's going to happen in 20% of the IBD population. And so you get that overlap phenomena, and I'm sorry, that happens to people. And it makes the picture confusing about how you treat those patients, because then you got to like kind of peel the onion and make sure they're not inflamed and then work through the IBS type issues. But again, that's another situation where you're going to get that chronic pain type of picture with those patients. And I also, before, just not to forget, we're focused on the intestinal tract, but there's other pain issues in these patients as well. There's extraintestinal manifestations like the joints, and that can be quite
Can you
debilitating.
can you clarify? Can you define extra-intestinal?
Right. Extraintestinal, that's a great question, Rebecca. Extraintestinal means that it is symptoms or signs or areas of the disease is affecting outside the gastrointestinal tract. So whether we're talking about the joints are one of the most common. So you'll see it in patients complaining about joint pains in the central joints, like your hips and your back, or your peripheral joints, like your fingers and your knees. You can get in 2 to 4% issues with their liver, that they have certain conditions with the liver, or in less than 2% with the kidneys. The growth issues we talked about, we consider that an extraintestinal manifestation of the disease. Oral ulcers, that's another extraintestinal manifestation of the disease. Skin issues, such as erythema nodosum, these tender red spots that happen usually in the extremities, or another entity called pyoderma gangrenosum, this almost like looks like necrotizing fasciitis, that flesh-eating sort of skin profile right there that you get. Those are all extraintestinal manifestations. And some of the patients with those will have significant pain associated with them, especially the joint related problems. And again, hard to put your finger on them. You can also get muscle aches, and that can be debilitating in some aspects.
And are those dangerous? Like the like the joint pain, is that going
Yeah,
to progress to something permanent?
can. It certainly can. So, you can get degeneration of the joints. It is an inflammatory process, similar to somebody with like rheumatoid arthritis or any of the psoriatic arthritis, any of the joint conditions where you get destruction of the joint from that inflammatory process. Now, that's relatively rare, but it still can happen. And so something that should be addressed for the patient. Yes.
And is there a way to prevent the pain from turning into more of a chronic phenomenon?
Um, so hard to answer that question because everybody is different in terms of their approach, their symptoms, and how they're doing it. I think first and foremost, to give you the best chance of not progressing there, is that seek medical care, get treated appropriately, reach those goals of treatment that we talked about, especially from the medical side, because that's going to stop the process at least or abort some of that inflammatory process and help the manifestations of the disease. I think the second is that if you're not getting where you need to be, make sure you're bringing it up to your provider because sometimes it is that certain treatments are geared for certain areas, but not others. So if you're having joint issues, some of the drugs that we have are better than others for the joint issues, and that will go into the calculus of the provider to figure out what's the right treatment or right approach for the patient. That said, even still, you're going to get some patients who are going to go on to chronic pain, and then that's where you need your friends like you, Rebecca, and the Zeltzers and others to help us in terms of how do we help these patients cope through this process.
And and what can parents do, or other uh, caregivers in the family, or other um, loving adults?
Yeah, I think first and foremost, um, love them, care for them, right? I mean, that's where it's at right there. I think equally important is to listen to the child, hear them, what's going on. And mind you, I have still two who are teenagers and one who's out of the teenage years. They're hard to listen to it sometimes because you got to like put your ear to the door to listen, right? They don't speak much at times, and others, speak a lot. And they speak in grunts or one word or anything like that. But you know your child best. And you know when they're being affected. You're watching their habits. If they're really not participating in the things that you know they enjoy, there's something amiss and something wrong. And so it's on you in that situation to kind of push them a little bit and bring it to the attention. As much as it frustrates them, as much as I sit there in the room and they're like, "Mom, don't mention that." It's okay. In the end, that's the right move. And we always say that to them. It's like, I need to know about this. Like, I got to help you out. If it's really affecting your life to that degree, I need to know about it so I can see what I can do to help you. We try not to dismiss complaints. You have others who are just have a higher level of complaints, but we try to listen to it all and kind of decipher what's going on and back it up with objective testing. Okay, let's see what your inflammatory markers look like. Let's see what your scope looks like. Let's see what your imaging looks like. Let's see how you do with this regimen for your chronic pain. Let's see how you do with the hypnosis or other sort of aspects of it. And I think the other advice I would give is try to normalize things as much as you can. That's what they're looking for. They're looking for normalization. They want to feel like they're everybody else. They want to feel like they're siblings or their peers and function in that way. So do the best you can to normalize aspects of their life and not draw as much attention because they're not wanting to that. They want to just get back to normal living.
I've sometimes found that teenagers in particular don't want to burden their parents by telling them about either their physical symptoms or about their emotional distress. And I'm wondering if that's a situation that you've come across, and what do you recommend?
I have. I think it's a great point. I think there's a couple of aspects to that. I would expand to what you're saying and say part of it is also sometimes they don't understand what's happening to their body. A lot of times when they bring something up and I'll say, "Why didn't you mention that earlier?" And they will say, "I didn't know it was abnormal." They don't know, sometimes that something like that is abnormal, or they don't want to burden anybody, or they don't want something that's going to take them away from their living, their activity, or anything of that sort. I think what my approach is in the talking to the patients. I try to be direct with the patient, especially the adolescent, usually in the room. I tell the parents, I'm not being dismissive of you all. I'm not trying to be rude to you all, but I'm looking at the patient. I'm talking directly to the patient because I want them to feel empowered to tell us what's going on. And the conversation a lot of times that we have is, look, it's okay. You got to tell me everything. Overshare and let me sift through it and say what's important, what's not, what do we need to address, what's not. But in your oversharing as well, tell me your goals. What is it that you want to do? And let me help you get to those goals working in through that symptom. So trying to take away that element of I'm not going to achieve what I want to achieve if I tell you about this. No, let's work through it. I'm supportive of you doing everything you want to do, but I also know that if you don't tell me about this, it can blossom to more that's going to take you out of this activity for a much longer period of time. And so we just need to work through that and kind of do that. And I encourage the parents to do the same. Like, tell them to tell you about the symptoms, but don't overreact to it and say, oh, now we can't do this anymore, or we can't go out with our friends anymore, or something like that. No, let's talk through it and let's figure out what the best sort of approach is in that situation.
Really finding that middle way.
Yeah.
Wow. And so, at what point do you recommend that a patient who's, whether they're newly diagnosed or whether they've been found already to have IBD, at what point do you recommend they see a mental health professional?
Um, Great question. Okay, we're lucky here at Cedars in our Inflammatory Bowel Disease Institute, as we have social workers embedded in our clinic. And so for any new patient that comes in here, whether we diagnosed or somewhere else did, and they're coming here to be seen by us, our mental health specialist, our social worker will see that patient right there and go over various resources. We're also fortunate and lucky because we have psychiatry who does consultative services both on our pediatric and adult side, that we can in our IBD Institute, and we can team up from that standpoint. So I want to make sure I put those caveats in there because I know not everybody has those resources uh, available to them. So any new patient who is diagnosed should have some, in my mind, addressing of the psychosocial aspects of their disease. Uh, if you have the resources, it would be great to be done by a mental health, somebody in the mental health field. A social worker is trained in that way, a psychiatrist, a psychologist, so on and so forth. If not, um, hopefully, our doctors out there have at least some basic resources and knowledge to kind of go through some of the psychosocial burden, some of the discussions about various things, and talk about resources. So there's a lot of resources out there. Programs like CHIP is a resource out there, but there's also resources from the IBD side of the world, whether it's coming through organizations like national organizations like Crohn's and colitis. Here in LA, we have a local organization called Connecting to Cure Crohn's and Colitis. There's resources of that sort where there would be peer groups, peer support, uh, uh, um, support groups, various aspects like that that help you in kind of dealing with the disease. And then obviously nowadays there's online resources and other aspects of it. But at a minimum, the provider, the medical provider, should at least talk through some of that right off the bat with the diagnosis. But hopefully, then we're connecting to other resources that exist out there. Not everybody needs a therapist. Not everybody needs a psychiatrist. Not everybody needs to go through that aspect of things. But we're talking about, 20 to 40% of those patients having those aspects. We want to identify and get them going through that.
Sorry, I'm just checking what's in the chat here. That, oh, CHIP also has a support group for youth with chronic
That's
pain
true.
that kids with IBD can join. Another pain-related question that has come up fairly often for me is, are there particular medications that you either do or don't want to use in somebody with IBD? And I would include cannabis in that because I think
Yeah.
a lot of people use it whether or not they tell us about it.
Yeah, wonderful question. Let's start with the extremes and let's talk about narcotics, heavy pain medications like that. We want to minimize those as much as possible. Um, Unless like somebody's post-surgery or there's absolutely no other route, we would try to avoid those for as much as we can. We want to avoid those type of medications. Let's talk about then move on to like something like a non-steroidal anti-inflammatory NSAID. So your Motrins, your Advils of the world. We try to limit our patients' exposure to those as well because they can actually have gastrointestinal side effects by leading to ulcers and causing GI inflammatory responses. So, chronic usage of that or repetitive usage of that is something we want to avoid. Now, you get occasionally a patient taking them once a month for a headache or for menstrual cycle cramps or something of that sort, and typically that's okay. But more often than that. Tylenol would be an okay pain regimen right there. Now, talk about the other side, which would be like cannabis type of material and stuff. When it comes to the cannabis, the data is not there yet in terms of whether it actually worsens IBD or helps IBD. There's been some studies that have shown maybe it can actually help the inflammation of IBD. They're not yet the high quality studies that we need to really make a conclusion on whether that has an effect overall. On the flip side, though, you can have obviously uh, mental aspects, mental effects of the cannabis and the marijuana. Um, if you have a higher propensity for psychological illnesses in the family, that can bring that out in a patient. So we really want to be careful with that. And chronic usage of it nowadays, we associate with actually a hyperemesis or excessive vomiting syndrome that happens in some patients right there. Um, Equally like alcohol, again, not one that we can truly say it worsens the disease or not, but not a healthy aspect. It's a sugar, and that sugar is going to feed the gut bacteria when drank in excessive amounts, and that can cause this distress and symptoms and so forth. And while we're at it, even though it's not pain related, just to mention it, nicotine, cigarettes, and vaping is the one thing we want the patients to stay away from, especially the Crohn's patients, as it can dramatically affect their disease overall. Now, there's other sort of medications that are used for chronic pain issues, whether that's your SSRIs, your serotonin type reuptake inhibitor medications, or other medications that you may have heard of, such as like Remeron or any of those type of drugs right there. Those are fine from an IBD standpoint. And those are commonly used. In fact, it started with pediatric IBS studies and using amitriptyline for those type of patients right there. And those are medications that we will give our patients from time to time to help them with their chronic pain issues. And then to end it with the non-conventional, the non-medication routes, the hypnosis that you do, the behavioral therapy approaches, the even the virtual reality type of pain management. We're on board with all of that. Like, let's try it. There's data to support it. Let's go for it. Uh, we want functionality back, and the side effects of those things are minimal to none. The interaction with the disease is minimal, so we really want to, give a try for those things.
I also sometimes traveling along with pain um, in the GI tract, sometimes we also see nausea. Does that tend to be an issue in IBD?
Certainly. I mean, nausea, as you said, it is I don't know about you, but it's the one symptom that I feel all of us gastroenterologists sometimes are like, oh, nausea. That's the troublesome because it can come from so many different areas. And how do you treat it? Yes. And having nausea can influence that list of medications we just discussed, and you will try things that are a little bit unconventional as well in that sort of situation. You can even try an antihistamine type of medication like periactin or something of that sort for the nausea. But definitely you're going to give a whirl to those medications. And we should also talk about that the newer IBS medications are a possibility as well. So those are drugs like Linzess, which helps treat constipation, and now approved for IBS as well in kids. Other drugs like Motegrity and the whole host of the other medications that are these newer drugs that are out. We can give those to the IBD patients. We don't want to give it to somebody who is a Crohn's patient who's scarred down and has a possible obstruction for that patient right there. But those are, a smaller percentage of our patients. But for the majority of patients, if they do have secondary motility issues, IBS issues that's leading to pain and problems right there, that certainly is a route that we want to consider.
Okay. And then, the new kid on the block in GI pain management is the percutaneous electric nerve field stimulators, which
Yeah.
I'm trying to not use the brand name,
Yes.
but there is really only one brand that's doing it. Are
Yeah.
those contraindicated in IBD?
No, they're not. They're not contraindicated. We do those in our clinic as well. And we've had a good number of IBD patients who have utilized those, especially those with the refractory nausea component, where you want that vagal nerve stimulation to see how they will respond to that, but not contraindicated at all.
All right. What else do you think is important for parents and families to know about pain in inflammatory bowel disease?
Um, I think we just have to harp on the point that pain can be a presenting symptom, but it's a non-specific symptom. It can come from a lot of other conditions and disorders. And it can correlate with the inflammatory load, but it can also persist after the inflammation is gone. And in that situation, yes, we've achieved our goal and we can be proud of ourselves that we've treated your inflammatory condition and you're doing great from that standpoint, and we've changed your trajectory and your outcome and your natural history. But if we haven't improved your quality of life and you're still debilitated by pain, then we haven't completely finished our job, right? That we got to work on that aspect. And so sometimes you got to think about uh, as providers, we have to step out of the box of just thinking, well, I'm just treating the disease and nothing else. And you got to start thinking about the whole picture of the patient and understand all aspects of them and help them out through that process. And there's so many resources, CHIP being one and others, that you really want to utilize those resources in that situation to help this patient get back that quality of life.
I'm also wondering, when kids do have chronic pain in the setting of IBD, how is that for families, and what my impression is that parents sometimes need additional support.
Correct.
Um,
I, yeah,
what do you recommend?
yeah. I would agree with you 100% that the parents need support as well. And let's not forget about siblings. If there's siblings in the house, they sometimes need a lot of support as well, especially since the patient has taken up a lot of the attention of the parents, rightfully so, because they, have a new chronic condition, and sometimes the siblings feel dismissed overall. Um, I think this is a growing, recognized area. A lot of the support groups that are offered from various organizations focus in on the parents. Some
Mm-hmm.
focus in on the siblings.
Mm-hmm.
And those are great resources for you to just be a part of, listen to others' experience, and help coping from that standpoint. Because if you're not healthy, how are you going to take care of your child who has the condition? To be in the right mental health state in a very stressful situation with so much going on in life, it's difficult. And so you need help sometimes in dealing with that before you can then maximally help your child through that process. And the children live so much to their world as a reflection of their parents. If the parents are stressed, they're going to be more stressed. If their parents are in a situation where they're telling them it's okay, they're going to feel more safe and okay with that. And sometimes that's incredibly difficult for people to do, but something that there are resources out there, and I would encourage everybody to get those for themselves if they need them to help their child out.
There are a couple of questions that have come up in the chat. Um, One of them is we've talked a lot about stress and the need for psychosocial support. Is it possible that chronic pain in IBD can occur without psychological issues?
Oh, certainly. No, I don't mean to suggest that it only happens with psychological issues. Chronic pain can certainly happen without that. As we talked about, you can get that hyperstimulation of the nerves in that intestinal tract and have chronic pain associated with that. The joints, chronic pain. So it is not all related to psychosocial stress issues overall. And this is an important distinction and discussion as well. So sometimes we talk about like, okay, you have chronic pain. We're not seeing an inherent inflammation there. There is probably some hyperexcitation or some aspect of it that's right there. And now we're talking about kind of how to deal with that pain, and talking medication approaches, alternative approaches. And some of those medication approaches will be in the same family that we use for the psychosocial aspects, will be used for the anxiety, depression. But we're telling you that we stress it. I'm like, I'm not treating anxiety or depression. It's the same nervous system effect overall. I'm just trying to blunt those nerves a little bit to become less excitatory in the abdominal area. So yeah, they don't have to be going hand in hand.
Mm-hmm. And it's also my impression that some of the um, psychological treatments aren't aren't recommended because there's a psychological problem, just because they're effective in retraining those nerve connections.
I completely agree. That's exactly right. So a lot of that exists. A lot of that is that, as you mentioned, it's just retraining that system.
Mm-hmm. A couple of other questions that have come up. What about acupuncture as a pain
I,
management technique?
yeah, I love that to try. For our patients as well, we actually refer them to acupuncture from time to time to see if that is a good approach for them.
All right. And touching back on the use of the um, for patients who don't have anxiety or depression and are prescribed a medication that is neuroactive,
Mhm.
can those medications cause a problem?
Very good question. All medications can have some side effects. That's why you're not going to give it to just somebody who doesn't have an issue. You're not going to start that IBD patient right off the bat as you start their advanced treatment for their inflammatory disease. You're starting it because they have some manifestation that would benefit of it, whether it is depression, anxiety, psychosocial issues, or whether it is, let's say, the chronic pain patient where there is data to support that these medicines can help in desensitizing those nerves, as you put it, Rebecca. And so now you're always weighing that risk benefit in terms of that. And here, the benefits start to outweigh the risks of those medications.
Always a calculation.
Correct.
No. Um, and for specifically for young women with IBD, do you see any relationship between pain and the menstrual cycle? And is birth control ever helpful?
Um, so we see a lot of connection there. There is something to be said about hormonal changes and symptoms of your disease. Again, similar to what we talked about, we don't know if it actually truly causes inflammation, but there's symptom associated flare-ups of the disease. The most evident one is when, you know, women get pregnant with IBD and their disease can change in so many different ways. So for those who are having intense menstrual cycle cramps, especially that we've taken away their ibuprofen usage, which is a good mainstay of treatment, we do recommend talking to their primary care or their gynecologist about doing hormonal medications to try to settle those and blunt that extreme response. There is a slight risk with those type of medications of blood clots. IBD, when it's active, is also a disease that increases blood clot risk. So we do recognize that that's a slight risk again, but that risk side is very low, especially in somebody who is treated for their inflammation and their disease is under control.
So again, a calculation to keep in mind, but probably not going to influence your decision making too
Correct.
much.
Yes.
Okay. Do you have any final comment that you'd like to make before we wrap up?
No, just to thank you all. Thank Chip. Thank you, Rebecca. Thank the Zeltzers for putting this together. It's been great to spend the hour with you all.
Thank you so much. It's been wonderful to talk with you.